an international
A gente vai do começo ao recomeço com você. A.C.Camargo Cancer Center. Você no centro, a ciência ao seu lado.
Well, good morning, everybody. Bom dia a todos. Nós estamos hoje com uma convidada internacional, então nós vamos comunicar em inglês. Good morning, everybody. Good morning, Evelyn Bischoff. Thanks very much for coming to A.C.Camargo. Dr. Evelyn Bischoff is here as part of a project that A.C.Camargo participated. It's called The Future of Medicine. Let's have a series of lectures, and she is a professor of medicine at the Shanghai University of Medicine and Health Sciences, president and founder of the Healthy Longevity Medicine Society, and affiliated to the Center of Healthy Aging at the Zurich University. She's a physician, a researcher, specialized in internal medicine, oncology, and longevity. And she has interesting research in geroscience, the science of aging. And she has research in the area of artificial intelligence and precision medicine and how it relates to longevity and health. So it's very interesting for us. Welcome, Evelyn. I have with me here Dr. Mariana Bright to help me in the moderation of this session. She's the senior manager of research at the A.C.Camargo Cancer Center. Welcome, Evelyn. Thanks for coming. You are at the A.C.Camargo. It's a very traditional session here at Wednesdays morning. It's 7 a.m. here in São Paulo. So we have this, I've heard we have this early Wednesday session since the beginning of the institution. It's a 70-year-old cancer institution dedicated to research, teaching, and treating cancer patients. So thanks for coming, and feel free to start your presentation.
Great, thank you so much. Really a great honor to be with you today. I really thank you for the invitation, and I really enjoyed my time in Sao Paulo. So I'm very upset I didn't come in person, but it's a great honor. And myself, I have a very strong interest in oncology, spent a lot of I'm working now mostly in, and also the topics are very strongly related. So I will share my presentation. If you allow me, I will switch off my camera just because of the connection, and I will dive right in. Okay, good. So I want to present two short presentations today because I thought maybe it will be interesting for you first to learn about healthy longevity medicine at large, and just to give you an introduction and some of the main topics, what we do, why we do that, and then to shift to geroncology and the field of, or the cross field between oncology and longevity medicine, and to show you some of the data that relates to that. Good. So let's start with the first one, healthy longevity medicine. In the year 2022, we actually founded a society, which was mentioned kindly just before. It's called Healthy Longevity Medicine Society. And I mention it because we have been together to actually try to define the field. What's the definition? What is that at all? What do we do? And we came up with this definition saying that healthy longevity medicine is a field that is trying to optimize health span by targeting age-related processes along the entire lifespan, which was trying to capturize that we are not about the duration of life. It's not our focus at all. Also, we are not dealing with old people or old age, not at all. We are all about health span. Actually, the field might experience a change, a shift from longevity to health span medicine, but it's all semantics. It's all about the words. The core importance is we are trying to optimize the values of every single patient on hundreds, if not thousands, of data points and billions if we do it longitudinally, in order so that the health span, the healthy lifespan will be as long as possible and the functional decline will be as low as possible. And most of those optimization processes we learn from age-related processes. So by studying geroscience, meaning the science of how do we age, we can then find out which processes, which therapies, which interventions are helping us to age better. And that's very much the capsular point. And the society is doing many things, but the most important around this is that we have working groups that are mostly working on guidelines and standards for the healthy longevity medicine diagnostics and interventions, and also how to make sure that healthy longevity is entering public hospitals. Of course, I'm sure you know that there's plenty right now of practices and private clinics, and it's wonderful, it's great, but it's not academic. And therefore, what we are establishing, and I will show you some examples, we have healthy longevity departments in public hospitals where we can also properly train physicians, students, junior physicians, of course, also senior physicians, and last but not least, to further see how can we implement healthy longevity medicine also for sick people. And this is where we will then see, okay, healthy longevity medicine is not only for the healthy and young ones, no, it's also for people who are not healthy and are not old yet. And so some of the highlights, perhaps interesting for you, is that there is already a set of healthy longevity medicine clinical standards, and those standards even have been implemented in the legislature by the government of the UAE, by the Abu Dhabi Department of Health. So this just to show that there are already countries that take it as seriously as it can be, by actually having the Department of Health and the government and the legislature to put standards in the constitution that will then define who is a longevity physician, who and where is a longevity clinic based on the standards of diagnostic and interventions. Now, you might have seen this graph many times, and I will just repeat it very briefly. So we are living longer, but we are not living healthier longer. We have a higher life expectancy all over the world, but usually the last decade of our life is in bed, in poor health, or at least with a significant functional decline. And that's something that we want to close. We want to close the gap between the health span and the lifespan. And that's being mostly done through geroscience, through healthy longevity medicine, and of course also through public health development, such as those clinical standards and much more. However, this gap is not only horizontal. So we know we live longer, but not healthy long enough. Another thing is, though, everybody is different. And if we look at lifespan and health span in a different way, in a graphical form, we know that the way of how the health span is really individual. Not everybody can achieve a very high level of health span. Not everybody can keep it very high for a long time, because patients have cancer, because patients have autoimmune disease, because there is a car accident, whatever it is. And this doesn't mean that healthy longevity medicine is not for them. So not only looking in a two-dimensional way at the health span and lifespan, we looked actually in three-dimensional way. We actually try to look for the so-called health trajectories for people, and we try to understand how much health span optimization we can get for every person along their lifespan. That sounds complicated, and it is, but there are good efforts, and a lot of things help us with that already, and some of them I will already show you. So as I mentioned before, there is the effort, and there is already actual healthy longevity medicine departments in public hospitals. Sheba Hospital in Israel is one of those. Now also our colleagues in Singapore and in Mayo Clinic in the US are in the process of building it. And we published a paper together just last year where we tried to put a very, very simple outline of a longevity protocol, of the pathway, of the journey of a person in such a clinic. And of course, it starts with a pre-screening, then with baseline assessment, and then with the analysis of those data, with the pre-visit in the center, with personalized care plan, and then of course touch points and maintenance program. The three centers that work together on that is Mayo, me in Sheba, and Singapore at the National University of Singapore. And luckily, many more centers are building up. Those are only clinical centers, right? We have a lot of very, very good research centers. Here, I'm only showing the ones that actually see patients as clinical patients, right? Not only for research. And that's the presentation for whoever is interested. You can look it up. This is how we describe how to build such a department, why it's important, and how it's done. Now, another point, which I will just mention very briefly, but I think it's important, is education. So we are all very busy as doctors. We barely have time to learn something new. We barely keep up with the news in our domain, especially if it's oncology. But healthy longevity medicine is coming up in a very rapid way. And therefore, there are efforts to also implement education on longevity medicine in the clinical settings. And one of those efforts is the Longevity Medicine Education Hub. For whoever is interested, it's for free, it's online. There are courses that doctors can take. It's CME accredited. It's also launched by the NHS platform. And those courses are giving a very, very good first impression and first knowledge base that can then later be developed and applied. And many, many students took it already all over the world. And even there are universities in the world, namely in Indonesia, Thailand, and now also in Lithuania, that have implemented this course into the university, into the medical schools. So also in our department, we are teaching the doctors how to do it. Now, the main question is probably, how do we do it practically? What is giving us the real data in order to optimize and in order to give the plan? So for this, we need biomarkers, and there are so-called biomarkers of aging. There are even consortia that are standardizing those biomarkers of aging. And the effort here is not only to know which biomarkers to check, how often to check them, but also to identify the biomarkers that will be needed to actually see how we age and how is the pace of aging. And that's very important because we need to know exactly what to check for or in clinical trials in order to make sure that an intervention is deemed as effective and efficient and safe or not. And so the movement is big enough right now, actually, where the White House and many other governmental bodies are deciding, okay, how can we put it even on a global level as a screening? So just very simple, like we have the clinical guidelines for colon cancer or breast cancer screening. Hopefully, and soon enough, we will have a clinical guideline on which biomarkers of aging have to be screened on a regular basis for a specific group of people. And that has a big impact, especially also for cancer patients, as I will show later on. So the concept of age and aging in cancer is not new. And the field that has been developed or named itself is geroncology. It's not geronco-oncology, the one that is dealing with the old age cancer patients. That's not exactly the same, although the name is similar. Geroncology comes from geroscience, and geroscience is about the field of aging, not about the geriatrics. So it's a little bit, again, of a problem of semantics. But the point is that we know that the processes of aging are having a very strong overlap with the process of tumorigenesis, of cancer development. And they are not only like almost parallel to a certain point, they also interact in between them on many levels as they progress further. This gives us a lot of hope, but also a lot of problems, because on the one hand, knowing the processes of cancer development is giving us a lot of hints, giving us a lot of ideas what we can do about aging. And many of the typical cancer drugs are being tested now for their potential as so-called geroprotectors and or senolytics. So, so substances that modify and slow down aging and or remove senolytic cells. Now, the problem is that as we age, we get more cancers, right? The highest and the biggest risk of developing cancer for most of the cancer entities is high age. So as we live longer, we have higher probability to develop cancer. Another problem for healthy longevity medicine is that patients, or a lot of people, are I'm so sorry, can you hear me again? So really apologize for that, and thank you for letting me know. There we go.
Please share your presentation again.
I'm trying. Okay. There we go. Okay, perfect. Right. So just gonna go back quickly to this point, which I started to say that the point that is not our priority, but it is still very important, is the fact that we know that sorry for that. I'm totally lost here. I'm totally lost here. So sorry. Sorry, I'm lost.
Okay.
I don't know what I'm presenting, and I don't know which.
I share your presentation.
Yeah, but I have two on the screen. I don't know which one you... Do you see the slide with geroncology?
Gerontology.
Yes. Okay, you see the right one. Okay, good, great. Okay, perfect. So once again, just to recap, and sorry for that. So a lot of processes of aging are overlapping with the process of cancerogenesis, but we also know that between the functional decline and the frailty, especially in cancer patients, there is a fine line, and a trigger such as chemotherapy or radio or something can bring a patient from pace of aging towards such an accelerated pace of aging that the functional decline will be tremendously lower. This is an important information because in health longevity, we are trying to see if we can optimize the pace, like the speed of biological aging for patients who are diagnosed with cancer but still didn't start therapy. And based on the improved biological age, based on this pre-cancer treatment longevity intervention, they might respond better to the therapies, have better prognosis, and also avoid the jump into frailty. For this, we need data. We need a lot of data, data that is barely possible right now to capture and to store. It's a big problem. That's why a lot of things is moving to so-called quantum medicine. But overall, of course, besides of all the tests that we do for a patient, functional testing, radiological testings, radionomics, whole body imaging, of course, very extensive lab tests with a lot of markers, very extensive checks for cognition and other point of care measurements. We also do check continuous values, right? So monitoring and specific panels which are helping us to track the patient. And that would include a lot of liquid biopsies, that would include a lot of trackers. Only of continuous glucose, but also continuous cholesterol, protein base, daily photobiopsies, and so on, and very often also use of metaverse hospital to capture it on. So basically having a virtual consult with a patient that is in the metaverse, so that there will be a capturing of the voice, of the movement, of the eyesight, of the retina points, to get as much data as possible to constantly feed a digital twin of a patient. Of course, that also includes optimally the whole omics, so from the whole genome through proteomics, lipidomics, and of course metabolomics in the blood. That kind of a map needs to be fed all the time, including microbiome on a constant base. And a lot of those data can be then used in order to measure the biological age. And the biological age at this moment is a variable that has different components, meaning there is not one full biological age of the entire body. There are different clocks for different systems, for different organs, for different parts even of the omics. And here is just a very small selection of those that we have. Those specifically are based on the deep neuronal networks. So a little bit of a chat GPI kind of technology with a lot of data points. We have, for example, very good hematologic, so blood clock, transcriptomic clock, methylation clocks, which are very popular right now also in popular media, but also clinical clocks and photo aging clocks and many others. And many labs also develop now biological aging clocks for specific organs. So we have good heart clocks and liver clocks and microbiome, but also gut health clocks, different systems. We do not make an average out of it because we know it doesn't really make sense. Every system, every organ is aging at different pace, and we actually want to know the paces of each of them. The interesting part, however, is that, and unfortunately it's still not published, it's still only in preprint, but hopefully very soon it will be online in Nature Aging, is the fact that there is an oncological clock. So we know that these biological aging clocks were mostly trained on healthy objects, but it was a question if those measurements can be also applied in cancer patients. The answer is, as I will show you later, yes, we can, but it's much better to have a specific biological clock for cancer patients, and even better to have a specific biological clock for specific cancer entity. So for example, the oncology clock that was developed based on lipidomics, the one that I just mentioned is in preprint, was specifically trained for pancreas and gastrointestinal tumors. And I believe, looking at the speed of how quickly the biological age clocks are developing, most probably, oh, apologies. Most probably those biological aging clocks will develop also very fast for cancer patients for different parts. I'm gonna skip those parts and go directly to the interventions. Apologies. Directly going to the interventions. So there are several different groups of interventions in healthy longevity medicine. Some of them, as I just mentioned, are in the group of senolytics and senomorphics. And some of them, some of them are so-called repurposed drugs. So metformin is a very strong potential candidate, but also rapamycin or any other mTOR inhibitors, rapalogs, some of the rheumatological medications. In terms of senolytics, the dasatinib and quercetin are very high in the front runner, and they came also from oncology. So they actually came from our field and are probably very, very effective. A lot of clinical trials are actually being now conducted as we speak. But there are also, of course, supplements, and it's a big question if they work or not. Microbiome plays a very important role, both pre, pro, and postbiotics, and symbiotics, so different ways of influencing microbiome. And something that is not a part really of our field, but closely related, so we observe, are the things of medicine, but published in Nature Medicine. Under the leadership of Tina, to the so-called exposome, so human exposome. And human exposome is basically the entity, the complex entity of all the influences on the human along the lifespan. So really also in a different dimension. And that would include all the external. We as doctors always, right? We know that the environment and the people and all the influences that we have from inside and outside are important, but now, thanks to the AI and thanks to the measurements in longevity medicine, we can actually measure it and capture it and make sense out of it. So that's what we call the exposome. And I will skip those slides just for the sake of time and jump to my next presentation, which is regarding some of the specific trials in oncology. Just a second, share window, this one, perfect. Share, wonderful, there we go. So, as I mentioned before, geroncology and geriatric oncology are not the same things, and I would like to outline those in a very brief point. So once again, our society is also looking at that, and there is actually a lot that can be said of how geroncology is not the same as geriatric oncology. In a very simple way, geriatric oncology is the knowledge on how to treat patients that are above 65 or 75 in oncology, while the geroncology is really a field that is trying to implement healthy longevity diagnostics and interventions to enhance the health span and also then the prognosis for patients who are undergoing cancer treatment. Now, different approaches, but the same kind of a goal is how to really optimize the prognosis predictions for people just at different levels. And in the geroncology, similarly to geriatric oncology, we know that we have a huge spectrum of people who are aging well or who are aging with frailty. But in longevity medicine, it's independent of the chronological age. We specifically look only at the biological age. And even more so, we are looking at the pace, like at the speed of biological aging. And we know that the spectrum is just as broad as general chronological aging. And we know how to treat the good group, we know how to treat the frail group, but most of the people are exactly in the spectrum where it's in the middle. And our goal is to have tools for oncologists on how to determine where the patient is in the spectrum of the health span, right? How can we with different types we know that the processes of cancer development and aging are so very much overlapping. We also look at differences within patients who are diagnosed with cancer at different points of time. So this is just a statistic that we did in Basel, so my place before, where we looked at new patient diagnosis for men and for women in different parts of their of the lifespan. And as we see, of course, with the age, the spectrum of different diagnoses is increasing, and along the time, this type of proportion is getting bigger. However, when we look at the aging and cancer in terms of vulnerability, and we compare the patients in terms of their biological age and chronological age, we see that we can learn from geriatric oncology the following. There was a study looking at if the treatment is beneficial for patients who are fit on the scale or who are not fit, and what to do with the patients in between. And the conclusion, sorry, what happened here? The conclusion was that in most of the cases, people who are on a higher spectrum of frailty development of chronological age still benefit from treatment, and only really at the highest level of frailty they stop benefiting from it. The question is, and so we looked, for example, at the geriatric oncology in our public clinic. When we look at what are the other symptoms and diagnosis of patients, and the older the patient, of course, we know the more diagnosis we have. Most of those diagnoses that were also increasing with age were cognitive diagnosis, so comorbidity increasing with age, and we saw that most of those comorbidities and those diagnoses are then directly related to frailty when treatment is initiated. However, when we looked really at where the problems were, they were mostly categorized as functionality, which directly relates to biological aging rather than chronological aging. And then also in terms of really the actionable items, it was related to nutrition and cognitive symptoms. What I'm trying to say with that is that people who are aging chronologically still develop different levels of functionality, and this different level of functionality can be probably also captured as biological age. So as trends have developed, geriatric oncology entered the public clinics, and there were guidelines developed for those patients, also knowing, of course, that the pharmacodynamics and pharmacokinetics of different drugs is different. So I'm not going to bother you with that, but I'm going to jump directly to the fact that there are already guidelines on that. And what we tried to do in our department in Basel was really to compare, okay, what can we do in terms of directly translating geriatric oncology to geroncology? And we had the flow. So we took patients who are over 75. We categorized them into different groups of cancers. And first we saw, okay, can we screen the patients who are old and screen them for geriatric assessment and also biological age? And two screeners were independent of each other. We used the GH testing and the mini cognitive testing, and we have seen that most of the patients who had an additional geriatric assessment actually benefited from it and were able to be referred to extra experts to optimize their general functionality. And after that, there was a flow chart that we have developed that was implemented as obligatory flow chart. So it was still in the study, now it's a guideline. So people who were over 65, they had tumors at all stage. When they had the diagnosis, they got a baseline geriatric assessment, and then they were randomized into either a very normal arm, so they were given interventions as we always do, plus being also led by geriatrics or other therapies that were needed, and they were followed. And the comparison arm was only given the golden standard without extra geriatrics or any extra therapists. And it was checked if they have developed chemotoxicity and or ER visits and or complications and or any other side effects of, for example, completing the therapy. And we saw, as expected, that those who were led by geriatrics and other therapists had statistically significantly lower overall toxicity and also hematotoxicity. They required less hospitalization, and not significantly, but also importantly, much less emergency room visits. Now, the question was, can we do something like that also in terms of geroncology? So as I mentioned before, we took this study and we made sure that all of our patients now as a standard are being screened by geriatrics, and they get standard therapy if they have no problems in terms of geriatric treatment, or if they have any type of geriatric assessment being not optimal. We took exactly the same graph and we made it also compulsory for geroncology, meaning we took all of the patients who were biologically 70 years and plus, meaning all of the patients who came to our department were also assessed for biological age through hematological age assessment, photo age, and methylation age. And once we saw that they are 70 years biologically or older, or actually now in a new version, we have also a delta of plus 5 years. So chronologically, for example, 65, but biologically 70, or chronologically 55, but biologically 60. If the delta was plus 5, those patients underwent further longevity diagnostics to understand what's their pace of aging. If they were normal, they went to the standard therapy. If not, they were discussed at the multidisciplinary geroncological board, which included also a physician, mostly internist, who is also well educated in longevity medicine, but also by other therapists who are necessary in order to adjust and optimize the patients before. So through either longevity interventions, senolytics, or other germ protectors, and of course lifestyle interventions. And that was really very successful and very useful, because not only did it help for patients in order for us to research and to get the data, but also help them to be more digitalized. So a lot of those patients, of course, also got a lot of trackers and monitors all around, and this reduced a lot of their visits in person. And ultimately, this geroncological approach then further helped the geriatric assessment, because we were able to learn how can we further optimize the geriatric patients with longevity assessments. There was also a very nice conference already in 2022 between Shanghai and Switzerland, on that topic, where we started to follow this specific protocol in gastrointestinal cancer patients, and that really led to a significant improvement both of their assessment and diagnosis. And one last thing that I would like to show is about the pancreatic cancer, which was very helpful because, you know, we all know the prognosis of pancreatic cancer. And in Shanghai, where we have the highest amount of pancreatic cancer patients in the city and also in the country, we conducted a study. We basically checked pancreatic cancer patients all across their stages from 1 to 3. We didn't include the palliative ones of number of stage 4. So highly palliative ones we didn't include. And we checked their biological age before the surgery and after the surgery, and compared to their chronological age. And we saw that their biological age was different. After the surgery, it was higher, of course, but also we saw that there was a gender difference. So actually, the females were more resistant to biological age change in a negative way than males, which is also important for us in order to optimize the therapy for them. Now the study is ongoing, looking at the fact of, can we actually really optimize the health span of those patients with pancreatic cancer in order for them to get the better diagnosis. And another secondary analysis that is still not published, that's why I'm not showing, is that all those patients who actually had a lower biological age at the time of diagnosis, they also had better outcome in terms of prognosis, which is not surprising, but it was never shown before in numbers. Great. So with this, I would like to finish, and I'm available for any questions. I'm sorry I went a bit over time.
Oh, it's okay, Evelyn. Thank you very much. Very interesting presentation. We are open to questions. You can use the chat at the YouTube transmission. Please feel free to ask questions there. And I'll pass now to Dr. Mariana Bright, who might have some comments. Thank you.
Thank you, Dr. Rubens. Thank you, Evelyn. It was great. I think it is very exciting to see your data. I think the way you started is very welcome in the sense that we hear a lot about longevity. And as academics, we are always not sure what we are talking about. Are we addressing science, or is this just wishful thinking? So I think that your data shows that we can take this into personalized medicine and really understand the molecular profile of each of the patients to bring that to clinics. So I think this is very exciting. I think last time we met, I made this question, but I'm going to do it again. When you're profiling the patients for biological aging, there's an opportunity also to profile for example, molecular targets of different drugs, or you can, piggyback on the approach of doing, I don't know, methylation profiling of aging and trying to understand what other information we can take from this molecular profile. Is this something you've been doing? What are you looking at?
Sure. Such a great question, and really, and so we are, a lot of this data that we collect is really also for the AI-based drug discovery, and we truly believe that the target will help us. We usually try to do the high output, so the whole methylation, the whole NGS, the whole genome sequence, and use that for evaluation. the plasma and the serum always with us as a storage. Trying also to have vaginal swabs for ladies. When we look at related to the cancer that is diagnosed or suspected. Yeah.
It's a matter of bioinformatics tools as well, right? Developing,
Yes.
taking that data and being able to look at the aspects. That's very interesting.
Yeah.
Let's see if we have some questions from the chat. I
just might have a question why we don't get any from the audience. But Evelyn, I don't see. I think I didn't quite understood which markers you use in clinical practice to establish biological age. In the protocols you've shown, some of them have been tested in some studies. You've shown which ones you actually use to classify patients in biological age, and do you need artificial intelligence to do that?
Yeah. Yes. Yes, we do need artificial intelligence, and I think everybody in the field of longevity kind of loves it because the faster it develops, the bigger help it gives us. And it's a great question. So there is a high number now of different biological aging clocks, and each of them uses a little bit different biomarkers to determine the biological age. And so, for example, the hematologic age takes 45 factors from the blood from metabolomics, but it's through deep neuronal networks. So yes, AI, and it's specifically generative AI, so ChatGPT type. Methylation, for example, takes the methylation pattern of the genome. There is also a microbiome, biological aging, so microbiome. There's telomeres, that's not as prominent anymore. And there is a variety of clocks that look specifically at organ age. So they would use a combination of data. So, for example, radiomics, from the structure of the fibrosis level of a liver, of a kidney, and then some of the metabolomic data. There is also very interesting clocks that use specific thermal images or retina images. Yeah, for the brain age is the MRI.
Interesting. So I think there will be a challenge to apply this clinically, the access to all these biomarkers and even the AI evaluation. It's a challenge to apply clinically. So what do you think about that? How can we get forward?
Yes. Yes. The departments, right, in public hospitals.
We're sorry,
And
Evelyn, we didn't get the last answer. If you could
sorry.
start again. Okay.
Yeah, sorry for that. Yeah. So I mentioned, yes, for sure. It's still I wouldn't say a long way, because the development is going fast and the prices are going down, and the validation will be faster than it was even a year or 2 years ago. But much bigger challenge, I think, is in the application of security and digitalization of hospitals. So many people now or even if you do them, they
I'm sorry, Evelyn. Once
to
again,
really use them in order
we didn't get. Sorry, we didn't get this answer. This last answer.
I'm so sorry.
The connection is failing. It's okay.
I'm so.
It's okay now.
Sorry for that.
It's fine.
Okay, let's hope. So, okay. So as I was trying to say that yes, it's a challenge, but as the tests are getting cheaper and more providers are available, probably just the access to the tests and connection results into the system of the hospitals, so that we can use that to combine. And like Mariana said, the bioinformatic part and AI part, that's still a big problem as we see it for many reasons in our, for example, in our hospital.
So we have a question from Dr. Sael. Mariana, if you can you see it?
Sure. So Israel is a bioinformatician here. So he's saying, great talk. How does the measurement of biological age compare to chronological age in predicting disease risk or treatment outcomes?
I love this question. It means really it's a right question, especially from bioinformaticians. So we need more validation, but already there is. So most of the biological aging clocks, I would guess around 80%, are predicting mortality, right? So they do predict at least prognosis of most of the things, and that includes diseases. But like you mentioned, we need to get much better to get biological aging clocks that predict morbidity, meaning the disease, and then the outcomes of those diseases. Some of those biological aging clocks do that already. So some of the methylation clocks, glycan age or glycation clocks, they do that. There are correlations. There were good data in the UK Biobank and NANHES and so on that allowed us to do that. And how this compared to chronological age is a very good question, because we are trying actually to get as much away from chronological age as possible as a predictor, meaning we are just training on the chronological age for the delta, but it's not anymore the clock showing us, oh, how good does it correlate with chronological age? No, we are trying to move in how good is this clock allowing us to see the delta between the biological age and the chronological age, and actually also calculating the optimal biological age of that patient. Yeah, that's the correlation, and different clocks will have different correlation to chronological age. That's why when you look, I'm 20 years old, my methylation clock. Yes, because this clock is allowing this type of statistics. But if you have the same difference in hematologic clock, meaning something was wrong with the calculation. So every clock, the doctor needs to know what's statistically correct for that specific clock. And most of them are well published.
We already have, Evelyn. I think that the Israel's question was interesting because he was trying to compare to the most basic marker we already have, which is chronological aging. And you are proposing to use all sorts of biomarkers, some of them that are hard to get, to get AI prediction biological age. So isn't there anything in between? Do you need all these markers? Does AI could help us to find a mid-term solution so that we could apply that more easily without having all those markers? We have such some clinical evaluations, such as performance status, that is already used in clinical practice. Have you compared the chronological aging to these measures of performance?
Yeah. That's a very good question, and the answer is yes. There are comparisons, and the answer to the question, do we need biological age? Is it a better predictor? Yes, we do. it's a much better predictor, and it's very often not correlating to chronological age in terms of prediction of prognosis or health status. Very often, most of the times, it's at least chronological age or the physical assessment, exam, whatever we do, is not exactly correlating, right? Of course, the first biological age assessment is your appearance. You, as a doctor, you can see. But to your second question, can AI help us to make it easier? What do I need to check for 3 terabytes of patients' data, or can I check just a fraction? And the answer is luckily yes. So because of this high level of data sets that we trained he can anyway. Also in Nature anyway, you all right. Thank you so much. You are muted. I'm sorry.
Yeah, you're on mute, Rubens.
Dr. Evelyn, sorry. we missed the last part of the last answer when you were talking about the AI helping us to find a mid solution to get the predictions of aging, biological aging. Are you listening to me, Dr. Evelyn?
Oh yeah. The Wi-Fi is getting more per minute. Yes. With a very small subset of data. So yes, we are on the way to get compromised. Yeah.
Well, that would be interesting to know about. Thank you very much. We are also almost getting to our time limit. Mariana, do you have any other comments?
No, I think that Evelyn needs to catch her flight by the way she's moving on in the airport. So we want to thank you so much, Evelyn. This was very interesting, and I think that we look forward to collaborating, to thinking about projects together.
I would love that. And really, thank you so much. And thank you for bearing with me at the airport. I'm so sorry it's like this.
Oh, fine. Thank you so much.
Thank you so much.
Thank you. Bye.
Thank you. Bye.
Tá isso. Muito obrigado. Obrigado, Mariana. Obrigado a todos. Um ótimo dia.
Ótimo dia. Obrigada.